Awesome. Okay. Can everybody hear me okay? Okay. Well, welcome to ITT Team 1, Part 2. Um, for those who don't know me, I'm Brad. I'm one of the first-year developmental behavioral fellows, and I'll be starting off the presentations today. I had the pleasure of seeing our patient, Calvin, last week and this week. I saw him last week primarily over telemedicine due to the expected inclement weather. And so we got to meet each other virtually. And I spoke with his mom at that time. And then his mom accompanied him to his psychology visit today, which you'll hear about at a later time. But I got to see him just to get a little face-to-face time and see what he looked like not on a video screen. So that's the context for my presentation today. And I'll be walking you through the content of our conversation and some of my thoughts about little Mr. Calvin. So there we go. So just to start, I'll be going through a little bit of Calvin's medical history. I will then talk about some of the presenting developmental concerns that I and his mom spoke about. And then I will, at the end, talk about my differential diagnosis, which is just a list of what I think could be going on with Calvin. So to go over his medical history, Calvin was born at 38 weeks, and so he was born at full term. And the reason that I always start with that is because I often think about, is the child term? And if not, if they're preterm, that can have a lot of cascading developmental after effects. And so with this term child, I'm a little bit less concerned for some of the developmental cascading after effects that can be seen in the case of prematurity. And a couple of things that were remarkable about Calvin's medical history is that he had a couple of what I would sort of lump into problems of infancy. And I call this that because it's things that we see not uncommonly in babies. One of those things was laryngomalacia, which is a real fancy term that talks about underdevelopment or floppiness of the larynx or the voice box. And it can cause young children when they're crying to sound like they are wheezing or taking in a big, great gasp of air and get all squeaky. And it is something that often goes away on its own. And sure enough, in Calvin's case, he was seen by ENT. They decided to watch and do nothing, and it went away on its own. Torticollis, as indicated by the second picture on the side here. I don't think this baby actually has torticollis, but he's looking to one side, which can sometimes be a sign of torticollis, which is essentially the tightening of the muscles in the neck that can cause babies to have, in a more milder form, like a particular side preference when they're laying down, or in its more severe form can be associated with kind of really significant tightening of the neck to one side, and potentially difficulty in other muscle groups. In his case, this was something that he was referred to for physical therapy when he was young, underwent about a 4-month course of physical therapy, and had resolution of his symptoms, as well as other behavioral interventions that mom described, such as rotating the crib every night so that he would want to look a different way at mom while he was sleeping. And then since that point, he has been essentially healthy. And what I mean by that is he may have had a few ear infections or illnesses here or there, but nothing that he has been diagnosed with that is a chronic illness, nothing that he requires medication for on a daily basis. And so no big medical problems there. Circling back to mom's pregnancy history, mom did have a history of hypothyroidism, low thyroid hormone, when she was pregnant, and required some medication for that called Synthroid, which is just giving you back some of the thyroid hormone that your body's not making. By the same token, she did have gestational diabetes, for which she took insulin. And a couple of these things, I think, contributed to the fact that at birth, Calvin was a very big baby. He was almost 4 kilos. It's like 8 pounds, 12 ounces, so big boy coming out. And that's not unusual when we think about a mom who has gestational diabetes. And I always ask too about substance use. As we've learned in our blend course, prenatal exposures can sometimes lead to different developmental outcomes. And in this case, mom denied any substance use when I asked about it. And so other than her medical complications, overall an uncomplicated delivery for Calvin, from my understanding, and he did pretty well in the newborn nursery, passed all of his routine newborn screenings, and all of those sorts of things. So aside from mom's medical history, a relatively low risk, early part of life for Calvin. Talking about family and social history. So in Calvin's family, he has an older brother named Malcolm who has been diagnosed with ADHD. And he also has a history of febrile seizures. No one in the family has a history of a seizure disorder. A maternal uncle of Calvin's has been diagnosed with ADHD and autism. And mom endorsed mental health challenges in other family members, including depression, anxiety. There may have been a family member in whom they were concerned for schizophrenia. And she did share that, unfortunately, Calvin's paternal grandmother did die by suicide. And so there is a history, there is a fair amount of psychiatric history in the family. From a social perspective, Calvin lives with his mom, dad, and brother. His dad is an airline mechanic, and his mom works from home in accounting, although she did share that she is expecting to be laid off here soon. And she shared that they're able to get by with dad's income. And so she's planning to spend some time with the kids over the summer. And so she was sort of spinning that into a positive, but she did bring it up when I was asking about stressors for the family. And so I think that could be something that could be playing into this too. And so just to summarize again, medical history, mom with a history of hypothyroidism and diabetes during pregnancy, but otherwise no big issues with Calvin's birth. He had problems that are common in infancy that resolved with relatively minimal intervention. And since then, he's been essentially healthy. And so with that background, I'd like to move on to talking about some of his presenting developmental concerns. And those of you who've seen my presentations from last semester have probably seen this basic format before. This is the format I tend to use for all of my new visits. So I look at things in all of these different domains, but one thing I wanted to highlight was some of the things that mom said when I asked what her primary concerns were. And she shared, she was worried that Calvin wasn't talking when he was 2 years old, but she feels like his language has really started to develop here in the last couple of months. She feels that he's improved by leaps and bounds. And she also endorses times where she feels like he disappears into his own brain, and it's hard to sort of get his attention, know what he's thinking, kind of get through to him. And so that's kind of setting the stage for me asking about some of these other different areas of developmental skills, behavioral, kind of affect, and sort of how Calvin gets through his day-to-day life. And so from a schooling perspective, Calvin has never been in school or daycare. He's never been in any sort of structured childcare experience. He's stayed home with mom as she works. Mom does work from home and is virtual. So she stays home with him, and they have a lot of fun together. As I mentioned previously, he was in physical therapy for a short course around the age of 4 to 6 months for torticollis. But other than that, he's never been in any therapies. He was never referred to early intervention and was never evaluated by early intervention. Shifting over to communication, I always like to break this down into a few different realms. Um, and certainly all of this with the caveat that I am doing sort of a quick and dirty top level assessment of what everybody, different disciplines goes into more specifics. And so I realize I am painting with a bit of a broad brush, but I try to split communication into expressive domains. How does he communicate with others, whether that's words, signs, gestures? How does he understand what others tell him from a receptive? How does he seem like he understands? Can he follow directions? Does he look at you when you talk to him? And then pragmatics. How does he get what he wants or needs? What sorts of skills is he using to sort of navigate through life when navigation through life requires communication with others? From an expressive language standpoint, Calvin is reported as someone who basically didn't have intelligible words or phrases until the past couple of months. And early in life, he was reported as having trouble with certain sounds like M sounds, not really saying mama until recently. He will say, now I want XYZ for certain wants. And mom later specified that he can say, I want juice, I want Nana for banana. And so does have kind of some basic like wants and needs vocabulary that he's starting to build. He did engage, this is a time when I typically also ask about some things that can be atypical ways that kids use expressive language. For example, if that language is repetitive or if it seems scripted in any way. Sometimes kids in whom we're concerned about autism will pull sort of scripts from their favorite TV shows and say them even when the context isn't really socially appropriate to be saying those sorts of things. And some of the things that he was endorsed to say would be things like Paw Patrol on a roll, or 3, 2, 1 blast off. Calvin loves rocket ships and loves treating lots of things like they're rocket ships, even if they don't look like rocket ships. And so he likes to say 3, 2, 1 blast off and make the thing he's holding blast off. He also was reported to engage in a little bit of echolalia, and that is basically when kids repeat back to you exactly kind of what you say to them, even if it's something like you're asking them a question and they repeat back to you the question that you just asked. And something that clued me into this is that mom said that before he was saying mama, he was saying to mom things like, hey bud, or hey booger, which is what she would say to him. And when he goes to bed to this day, he will say night, sweetie, which is what mom says to him. And so very, very sweet. But something that makes me wonder a little bit about an atypical use of expressive language. From a receptive standpoint, Calvin is reported to follow directions well, especially the more specific you are, the better he does, which I think is generally true. It is reported that it's sometimes hard to get his attention. If you call his name, he might not look up from what he's doing, might not look at you, might not attend to you. His eye contact was described to me by mom as pretty good when it happens. And so some description here of inconsistency, but also times where he will sort of meet your gaze and really seem to follow along with what you're saying. And then from a pragmatic standpoint, so prior to the last few months when he had this sort of growth in some of his vocabulary to express wants and needs, he would communicate wants or needs primarily by screaming or by whining. He would, the family says they have a gate at the kitchen and he would stand at the gate into the kitchen and he would just sort of scream or whine and not really use words or use pointing to indicate what he needed. Now he will use, again, that sort of, I want this, I want that. He's reported to be able to point with one finger. And then I also like to ask at this point about joint attention, of which you can see an example in this photo of a child who is being asked to look at something and follows the point of her mother. That's a little bit more of an appropriate response to joint attention. And so when I ask when a kid initiates joint attention, that's a kid who will say, oh, mommy, look at that, and looks back to see if mom is looking at what he's pointing at. And then response to joint attention is when mommy goes, hey, Calvin, look at that. And he follows that point to look at what mom's looking at. And so he was described as a kid who doesn't really initiate joint attention a whole lot, and has a variable response to it, doesn't always respond to it consistently. And then another thing that I sometimes ask about will be, does he seem interested in involving you in his play or showing you what he's doing during his play? Typically, an indicator of strong social emotional development is when a child will be playing with something and they'll say, oh, mommy, look at this. And they'll hold up whatever they're doing and they'll be so proud. Calvin is described as a child who doesn't really do that a whole lot. Moving over a little bit more strongly into that social and play domain, Calvin is described as a kid who has limited interest in other children. He mostly engages in solo or parallel play, and so he'll play by himself or he'll play in the presence of others without necessarily interacting with them a whole bunch. He's someone who's also described as relating better to adults than to other children. And certainly, some of this could be related to the fact that he doesn't have a whole lot of experience in that structured like childcare setting, or has relatively inconsistent kind of same-aged peer interactions. But even with his brother, they may like wrestle and he may seem to enjoy that, but otherwise they're mostly kind of doing their own thing separate from one another. As far as some of his play activities that he likes, he is reported to like Paw Patrol toys or cars. And again, everything is a rocket ship for him. And so he will say 3, 2, 1, blast off, and there it goes. And so he enjoys kind of pretending that things are rocket ships. From a motor standpoint, so overall, I tend to ask, any concerns about not meeting gross motor milestones on time, any concern about fine motor skills. And so going through that, Calvin was described as a kid who met most of his gross motor milestones, and there wasn't really any concern about him being able to sit up or crawl or walk on time. Mom did raise a little bit of concern about toe walking, and shared that with us, but otherwise felt that he is pretty able to navigate a room, has some pretty good coordination, is not super clumsy or anything like that, doesn't seem to have balance issues. From a fine motor perspective, he is characterized as someone who can use a fork and spoon pretty well, which is great for his age, and still working on drinking from an open cup, which is another skill that can come about around this age or before. In terms of thinking about his activities of daily life, from a sleep perspective, he is a pretty good sleeper, which is an awesome skill to have. I always tell families when they tell me their kid's a good sleeper, they need to bottle it up and sell it. They'll be millionaires. He sleeps for 13 hours a day. And that's between nighttime, like 11 hours, and a 2-hour nap during the day. And no issues with snoring, no issues with restless movements in the night, no issues with fatigue. Bedtime isn't a fight. He will go to his bed and say, night, sweetie, and that's that. From a diet perspective, he wasn't characterized as a particularly picky eater. He was reported to love peanut butter and jelly sandwiches. And overall, one thing that Mom did describe that was that she felt was unusual about his eating habits is that he has a preference for wanting what is on his plate to be described to him. And so if he doesn't hear what is described on his plate, then he will not be super fond of eating it, which I thought was interesting. From a toileting perspective, he is not yet toilet trained, although he is showing some interest. He has had some success in having outputs in the potty, and he's pretty interested in sitting on the potty, especially if raisins are involved, which are a favorite treat of his. And so I think definitely developing some skills in that area, but not quite all the way there in terms of daytime or nighttime continence or anything like that. And then in the realm of just kind of like some general self-care things, I often tend to think about that in these little ones as like, how much are they helping mom and dad do what they need to do to get through the day? And a lot of that comes when you think about like dressing, undressing, what happens at potty time, what happens at bath time. And it sounds like he's pretty willing to undress himself. when he is going to the potty or when he is getting ready for bath time, and does help with getting dressed at this stage, like holding out arms for the shirt holes and everything like that. Moving a little bit more into repetitive and restricted behaviors. This is something that I wanted to spend some time on with Mom, just because of the concern for autism and repetitive and restricted behaviors being kind of one of the two big diagnostic pillars that we tend to think about when we're thinking about autism spectrum disorder. Motor mannerisms that were described by Mom. Some of the more common ones that I ask about will be hand flapping, finger movements, spinning, and nothing really along that line that had Mom concerned. She did at this point bring up again toe walking, which we had talked about previously. Something else that I ask about sort of along these lines, which is a little bit of both like a motor mannerism, but also can be like a sensory interest, is kids who engage in visual inspection. And so holding up things really close to their eyes or looking at things from unusual angles. And she did endorse that sometimes he will like lay on the floor. And I did see him do this on the video visit, that he will like lay on the floor and be sideways while he rolls the car back and forth in front of his eyes. And so sometimes that can be representative of kind of like a sensory interest. As far as like changes in routine or behavioral rigidity, he is characterized as a pretty flexible guy, not a big deal for him to transition from one thing to the next, not a big deal for him to have his routine change during the day. Restricted interests, we've talked about treating toys like rocket ships. I didn't see him do that quite yet. But another thing that I would add to this category is that Mom did mention that he does have a couple of particular favorite toys that he will often like to carry around with him in his hands as he moves about the house. He brought one of those with him today, which was his little airplane that he liked to carry around and just kind of roll around on the table, but always seemed to make sure he knew where it was. Calvin was reported to engage in quite a lot of sensory seeking behaviors. For example, loving to run his body into things or into people, such as his mother, at full force, and really seeming to enjoy that like physical sensation of that impact. Big climber, big jumper, big bouncer, has a trampoline at home, loves to bounce on that, loves being held upside down, loves the feeling of vibration. So sort of a lot of those like very tactile kind of sensory inputs that he enjoys. He was described in the realm of sensory difficulties as having some difficulties with like bright lights or sunlight, like if he's in the car seat, even with like a tinted window and a window shade, if the sun is out, he's like, I don't like that. But otherwise, not a whole lot of other sensory sensitivities that were described for him. From a behavior standpoint, he was described as being a pretty active little guy, and I would say more in his home environment than in our environment. I felt that might be true of him, but his mom felt like this was nothing like what his older brother, who was diagnosed with ADHD, has in terms of hyperactivity or anything like that. In the realm of like temper tantrums, behavioral outbursts, this was characterized as not a big problem. He would be more prone to these when he is tired, when he's approaching bedtime. But the way Mom described it is that he would sort of get upset, fall on the floor, kind of flail about for a little bit, say, uh-oh, and then get back up and proceed with whatever he was doing. And so tantrums, outbursts were really characterized as not a huge area of concern. He doesn't engage in any behaviors that are harmful to others, and he's not reported to engage in any self-injurious behavior either. And then moving on to some of my observations of him, as well as things that I noticed on my physical exam for him. So, you know, on the video, he when asked by Mom to greet us, he did say hi and sort of waved to the general area of where we were on his computer screen at home. And he was seen to be pretty active, but I didn't get a whole lot of a chance to get a sense of sort of like what he was doing through the format of video. And so I did spend about 10 minutes or so with him today in a room just before his psychology visit. And what I noticed from him is that it was difficult for him to respond to his name. There were times when he would establish some eye contact, but maintenance of his eye contact was very limited. And so he would look at you for a brief second, make eye contact, and then sort of look away at whatever else he was doing. He would have some words that were also mixed in with some atypical or repetitive vocalizations. You know, I asked him what he had in his hand, which is airplane, and he said airplane, ga, ga, ga. And so has some words and word approximations, but closely intermingled with still some babbling, some jargoning. And he was pretty good at responding to some sort of very patterned social interactions, like saying hi when you said hi to him, but overall seemed to have pretty limited interest in involving either his mother or us in what he was doing. On physical examination, just a couple of things that I noticed and wanted to point out. His tone seemed to be normal, but I would say a little on the lower end of normal. Seemed a little bit floppy. And on gait, it's a little bit tough to describe, but the way he was walking was as if he was sort of deliberate and kind of like feeling each step. His gait seemed a little bit heavy, a little bit slow. Balance seemed okay, and I didn't appreciate any toe walking, but he was just sort of like very almost deliberate, and you could really hear him sort of stomp with each step. And so those were some of the things that I picked up on being able to see him in person. So to summarize those behavioral concerns, he is a kid who presents with some social strengths, but overall restriction in his social interactions, especially with children or with same-age peers. He does have a few restricted and repetitive behaviors. And overall, he's a kid for whom behavioral concerns are not a huge issue. So then, taking all of that together, I'd like to talk just a little bit about what I think may be going on with Calvin. And so, putting the pieces together, this is a 2-year-old young man who overall has a pretty benign medical history. He does have speech delay. He does have some atypical language, and he does have some atypical social interactions. And he is someone who is reported to have some restricted and repetitive behaviors, especially more in the realm of really strong sensory interests. But overall is pretty well regulated behaviorally. And so when I'm thinking about what might be on my differential diagnosis for a kid like Calvin, I think my primary considerations do include autism spectrum disorder. I think there's enough sort of restriction in his social interactions that I was able to observe and that was characterized by mom for me to still consider this probably my primary diagnostic consideration for him. Other things that could be going on for him, certainly, this could kind of be related mostly to a primary speech or language delay. I don't know that that would totally explain away some of the sensory interests and things of that regard, but it would potentially explain some of the differences in social interaction that he displays with. Certainly something that could be on the table for him would be something along the lines of global developmental delay. I didn't get the greatest sense of exactly kind of where his cognitive or pre-academic skills lie at this point. But given that he already has kind of that one area of speech delay, a delay in other areas would make him eligible to receive this diagnosis. And something I have in the back of my mind for him that I am less convinced about after meeting him would be something like emerging ADHD. There is a family history, certainly, and he is described as a kid who's pretty active. It can be really tough to suss out whether that is developmentally normal at this age, especially. And so certainly he would be too early to meet criteria for a full diagnosis, but it could be something that we would monitor for as time goes on. And so certainly, I think he's in the right place. Um, he would benefit from seeing us. I do think he would benefit from formal testing for autism spectrum disorder. And I think no matter what his diagnosis is on the other end, certainly I see some speech therapy in his future. But among potentially others, as we drill down and figure him out. At this point, I'd like to hear if anybody has any questions. Yeah, Julie.
Just a question. Did he come to us because of mom's had intuition, or was there a primary doctor, given he was relatively young? Like, how did he end up in our, was it mom?
Yeah, so I think mom had some concerns about his development, primarily related to speech. I mean, he's also someone who, in his primary care visits, had failed a couple of the MCHAT screeners, which specifically look for symptoms of autism. And he graded out as high risk on a couple of those. And so that's what brought him through the door as someone for whom we're suspecting autism.
Some more question for learning, because I'm passionate about the question about whether or not parents had used substances and the child was exposed. How do you go about asking that question in your practice? Because I think we can all learn from each other. And the reason I bring it up is the one time that Pam was out of Next Step Clinic, and a colleague of hers covered, she came back and teamed with us and said, oh, I asked the parent if they used drugs during pregnancy, and the parent, who was a bio parent, substance use disorder at the time of pregnancy, said no. And so my learning was, well, their perception of drugs was illicit drugs. So I just think we could all, learn from that. And I would love to hear how you ask it, because I know I can probably do better in my meetings with families as well.
And my approach on this has changed significantly in the past few months. I've had the pleasure of taking part in an echo related to specifically fetal alcohol spectrum disorders. And so they've given some great advice on how to approach this question. The way I typically go about it is I will ask if there were any complications with the pregnancy, and that typically we will talk about, like, what happened medically, did the baby need to be induced for any reason, sort of what happened medically. A lot of times during that time, we'll talk about if there were any medications that were used during the pregnancy. But sometimes I will ask that question specifically again, just to see if there was anything that mom was prescribed that she was taking during the pregnancy. And that was something that I know that we highlighted too in our SCPM work. So that was another thing that I sort of built into. And then oftentimes moms may be in a situation where they may have been using substances up until the point that they learned that they were pregnant. And for different moms, that may be a varying amount of time into the pregnancy. And so I will often ask, how far along were you when you found out that you were pregnant? And based on that question, then I'll go forward and I'll say, at any point, prior to finding out that you were pregnant, had you been using, nicotine or tobacco? Had you been using alcohol, or had you been using other substances? And so that's the language that I typically use. And so that may not be specific enough, but that's.
I think that's great, because I've been reviewing, as part of that clinic, I review a lot of histories to see if the child will qualify to be seen by us. And you'd be surprised, people will just write creatively exposed. And I'm like, I hope we get to a place sometime in the world that we can have a better idea of, like, oh, if they were creative exposed to this substance, we have these treatments that map on. And if we don't ask the question, then we don't know. And it's really hard to get any kind of, slicing and dicing of where those kids can benefit from intervention. So I just encourage to do what Brad does for everyone.
There's a question in the chat. Leslie, do you want to ask, or do you want me to speak?
Sure. Can you hear me? Can you hear me?
You're a little muffled, but I think we
Okay,
can
I'm
hear you.
sorry. I was just wondering because I think there's so much stigma associated with alcohol and drug abuse, or it's there. I used a stigma. But I am wondering if starting with the conversation with I have a question to ask you that has some stigma associated with it. And this is a safe place without judgment. Just like putting it out there. What do you think about that?
That's a really great question. And I certainly, there are some times where I have felt that I do use that approach and sometimes that I don't, which itself is a source of bias that I can work on. I have found more recently that for whatever reason, I don't say that. And I think potentially that I should try to universally say that. I think I go back and forth on whether by not calling attention to it, I make it seem more like routine and more like impartial and not judgmental by doing it that way. Versus I also think that I also appreciate that question, Leslie, because I think it's a totally valid approach. And I've taken this approach in the past where I say, I ask these questions of everyone and I'm not asking, these questions to be judgmental or to be punitive.
I think that, yeah, it's such a good point because I think nobody probably does the best job asking about adverse childhood experiences in general, so we all can do better. It's not just the exposure question or that kind of thing, but just in general, I think we as healthcare need to do better talking more openly about that. So there is this kind of semblance of could we do both, and there's a lot of questions that we might ask today that carry stigma, but this really helps us get a better full picture and then kind of go into some of those things that are, social determinants related.
This is somewhat different, but maybe be used in it. One question that we have to ask in OT is about, behavior and you write a behavior plan if the patient has, self-injurious behaviors or injury to others. It can often be an uncomfortable question for caregivers to answer because they're maybe insecure that their child can have dangerous behaviors. And the way I word it is I always wait till we get down to the emotional regulation piece, and I'm kind of talking and gathering, inferring about things we've already discussed. And then I say, this is a question that we ask everybody that walks into our clinic, and we want to do this to guarantee that we create a safe space for your child and a safe space for the other children that come into the therapy gym with us. And then I ask about the behavior. So I'm wondering if there's a wording that we can say we ask these questions so that we can gather the comprehensive data, but also make sure we choose the best treatments for your child or something like that. That would, offer them oh, okay, then let's share this. Just bring that up.
I like that better than what I've done historically, where I've just blamed it on insurance. Oh, we have to ask this for insurance.
It's, if we haven't already, that'll be a very interesting question to ask in our moms. How do you think this is best asked in a healthcare setting?
Gotcha. I think that word stigma would be triggering.
Stigma, yeah.
Sorry, when I heard Leslie ask the question, I think that just even using the word stigma, I would shut down instantly and not hear a word you said afterwards. So a different way around it, but I think that word is so, you're already oh God, you're about to judge me, whether that's your intention or not, that word's big. Some people might not know what that word means. Well, right, exactly, right.
Yeah, I think I had a pretty a similar reaction to Julie kind of here. And I think I like explaining why we ask the question so that it kind of doesn't kind of bring to light or cause any feelings or memories of when they've been stigmatized, but explains why we have to ask something. Stigmatizing reasons or I like that. Yeah.
So I had two follow-ups. Brad, Mom endorsed concerns about toe walking. I'm just curious if you found out anything more about that. Sounds like you didn't see it on video, but I wondered if she shared how often he toe walks, if he does it more in shoes or not in shoes, or when he's upset, that kind of thing.
Those are great questions that I did not ask. And I did not personally see the toe walking for myself. And so I think that didn't trigger me to remember to ask a little bit more about it.
So they'll do that, was that? You said it wasn't. So good.
Yeah, it's not gonna take long. I mean, PT will in their assessment,
Yeah, Mom brought that up, when I just initially asked about her primary concerns, and I didn't see any toe walking either, I don't think Lindsay, you did either, but he was wearing shoes and she mentioned that it. I don't know if she mentioned it was all the time when he's not wearing shoes, but it more frequently happens when he's in socks or barefoot.
The other thing was about the low muscle tone, sort of.
they're coming at you from all
Let's do it.
angles.
So, having done some telehealth appointments for kids with like cerebral palsy and whatnot, we've done tone assessments, we've guided parents through tone assessments, you know, to do it fast, and so we watch. But can you speak a little bit more about watching someone move and, how you might feel they have like low muscle tone versus weakness? You know, it's like the feeling, someone's postural control, but versus like a physical exam. Like teasing that out a little bit.
That's a great question. And so like teasing out, like the question is like teasing out low muscle tone versus just muscle weakness, like just by looking at them. I don't know that I have a great answer for that.
The seems really helpful. The physical exam is really helpful. Parents can do it for you if you guide them through what to do really fast. But like you were said something about like, he seemed to like slide through mom's arms or something when she picked him up, or there was something you mentioned that sometimes. But then again, it's like, I find low muscle tone and weakness to be hard to distinguish. But
Give us some pearls.
give me some pearls.
Sorry, thanks.
But just to add to Sally, so my question was, and I touched on very like less tone, but my question was the stomping, like the intentional walking seemed like a strong walk, the way you were describing it. Not as like soft. I mean, I guess there's varying degrees, but I was thinking of tone too when you said that.
I guess maybe I would describe it, it's so tough to describe. Maybe I would describe it a little bit less as stomping. It felt, I will say that the gait felt immature for age. And it was very sort of deliberate and slow. And I'm not sure if that's coming from a place of muscle weakness or tone issues, or if that is another sensory component, if it's more that he just feeling every step and enjoys the sensation of his body, of his feet hitting the floor.
That's what I was gonna bring up, the sensory piece, when you said that he likes to run and crash into mom.
Oh, yeah.
So like, I think he's probably seeking out tons of input to his body. And when you mentioned that, I'm walking up and down the steps, it's immediately what I thought about too. And he has full body awareness, something like that, he's just trying to get that feedback, but we'll find out more.
On that note too, we do not have a referral yet for OT or PT. So.
Can do. Yeah. Can do.
I just wanted to add that I saw him today, and I did see some self-injuries you won't be aware of, and just when you see him next, he was really upset because he wanted to leave and mom said no, and so he ran into the door, I think by accident, hit his head really hard, and mom had a very big reaction to it. It's like, oh, you know, and then did it again and kind of looked at her and did it a couple times, on the wall. And was looking at mom, so just so you all are aware. I think that was brand new, she had never seen that before. Usually it's like his body hitting the wall or hitting the floor, it's usually not his head. So.
This is random, but it popped into my head that as something mom mentioned that I felt
I couldn't speak to. She mentioned something with his eye. Did she mentioned this to you at all? He had a long haircut, I guess, about a month ago, and don't you notice some like eye drifting to one side? I heard if it was like in or out, like, because his hair was covering his eye, and it stopped like a day or two after he got a haircut. That was something that I heard before, but I just wanted to put on your radar. I don't know if that's concerning. I didn't notice anything in his eyes.
If it really was related to like the haircut, I guess my wonder would be if he was like looking at it, if he was like had that like sensory interest, especially I guess if it were like an eye problem or a brain problem, I don't think it would be dependent on his haircut. It is my thought, but I think to me that sounds a little bit more like I'm very interested in looking at this piece of hair that is right here in my nose.
Should we move on? Anybody else have anything to add? I don't know how to do it. I got it. No, I got it. Like, I don't know what to do. Like me either.
All right, gonna jump on in as another intro. I'm Carrie, Child Life. I specifically work with our adaptive care team, and so I do not typically work with patients that are 2 years old. Our criteria for our program is 3 and older. So this really brought me back to scary, like old Child Life days, which I will be bringing up some other things here shortly. Maybe this will work for me. All right, we'll just hit the button. Okay. As before in my presentations, I've talked about our psychosocial risk assessment in pediatrics. It's our kind of child life assessment tool that we use. But I did not use it for Calvin in this case because it is only validated for 3 and older. So I got to skip this. So like I said, brought me back to some old child life days. So some of the things that I actually like had to dig deep and think about my certification exam are the many developmental theorists that we are tested on for our certification, like Erickson, Piaget, Bronfenbrenner, like all kinds of stuff. And I was like, I'm not happy that I'm cool not having to worry about these people in my current job. So some of the stuff I won't cover as much as I've done with the last patient that we had, just because of his age and wasn't able to capture as much kind of relevant information. So just going back, and I'm going to try my best to skip over things that Brad already talked about so that it's not a duplicate for you all. So for ACT, we look at our stressors and our triggers. So waiting for preferred items, specifically mom said like food and drinks. Sleep routine, I think that's kind of more associated with being tired, that he doesn't want to go to bed. Like most toddlers, they want to keep playing. Like, no, I'm not really tired, but I'm so overtired that I'm going to hype up and ramp up because I don't want to go to bed right now. Not getting what he wants, and then some communication barriers, not being able to communicate his wants and needs very effectively. Reactive behaviors she shared was crying, screaming, throwing himself on the floor, so kind of tantrum type behaviors. She said he does kick, but that's isolated to diaper changes, and he'll slam his body into a door. Kind of talked about that being like a standard of like he does that once a day. So these behaviors, the crying, screaming, throwing himself on the floor, are pretty isolated and they don't last very long. Some things that help comfort him and kind of help him calm in those moments, giving him some time and space, quiet space, time with mom, and a lot of his preferred TV shows that I'll talk about later. So his adaptability, mom reports that he typically does really well with changes. I asked about going from a preferred activity to a non-preferred activity. She's like, well, I just like hype it up. But sometimes when he's in his own world, as Brad suggested, it's really hard to kind of get his attention, and divert him away from whatever he's working on. Mom described him as a fantastic toddler and her most active kid. He's really independent. I was really disappointed that I didn't get to meet him because if you look at his epic picture, he's like towhead, these big eyes and this cute little smile. I just wanted to scoop him on up, so. Communication kind of already covered. Some of the receptive language that kind of mom mentioned is just like concrete information, being very specific. I mean, mom, I have a lot of praise for mom that I'll talk about later, but she's doing an amazing job with if he's engaging in something that he's not supposed to be doing, kicking. Standard, most people are like, stop that, don't do that. And she's very specific of stop kicking me. So she's telling him what she needs him to do. Does well with demonstration modeling, and mom uses a lot of first then, especially with those transition pieces. So again, being a rock star about things that I would suggest, she's already doing it. I'm like, you got this, mom. Brett already talked about sensory stuff, really the sunlight. And then she talked about this puppet that they have. It was really hard to tell if he just didn't like the puppet in general. Mom kind of mentioned it, she thought it was more of the texture of the puppet, but anytime they got it out, he like ran away from it. I'm like, well, some people aren't down with puppets, so maybe that could be it. He's very active, as mom said, and she also mentioned like he likes to dig his feet into things, like into her or like into blankets and stuff like that. So whatever that could be. No stimming behaviors, as Brad mentioned. One question that we in our ACT program often ask is about pain. That's something that I wasn't able to ask about. A lot of patients that we see either have like a very high pain tolerance or like really hypersensitive to pain, like along with that touch sensitivity. So a question I normally ask our families, I just didn't get to it with our timing. He has a lot of interests. Mom showed us the room she was in. It was like his playroom and it is like packed of stuff. I just think like as a parent myself, I'm like, oh my gosh, I would not want to clean that. Like I can imagine all this stuff all over the place. So, I was really excited about how mom described some of his play since we didn't really get to see that. Does a lot of solitary parallel play, which based on like part and stages of play, like he fits into those categories there. He really likes some TV shows, Miss Rachel, Sesame Street, Paw Patrol, has tons of books, likes tractors, anything with wheels, little people, spaceships, as Brad said. He turns anything into a spaceship and does the 3, 2, 1 blast off. Blocks, knocking him over, really active. He likes wrestling and fighting around with his brother, climbing, jumping, and he does swim classes. So that's kind of really exciting for him. One thing that was kind of like shocking being like almost 2.5 that mom talked that he likes to do pretend play a lot. And so I was like, well, that's, interesting, thinking about like play development that I felt like he was kind of on an early end of, pretend play being on the low end of 2.5 there. So my strengths and some concerns, mom, I think, she's doing a great job, all the things that she suggested, like the first then, the specific directive statements, great. He's independent, playful, and of course he's adorable. How could you not want to give him a little hug and stuff? I'm glad I didn't see him today because I probably wouldn't have seen our other patient. I'd be like, oh, I'm too busy. He had that big, huge growth period with his speech and some other development. But my concerns with him is something that mom very much like acknowledged, and I felt like she was saying this preemptively for us not to judge her, is that she said, I work from home. He has basically like, he sits in front of the TV a lot. And, we all have to do what we need to do, but, screen time is associated with kind of like delays in our social development and our speech development, language. So those, I'm not a doctor, but, to me, something that could be related to some of the things that are going on. And then like limited peer interactions. He spends a lot of time with adults, so he doesn't get a lot of time with kids his own age, and with mom working, he's not getting a lot of kind of maybe one-on-one time with a person. So he's kind of having to be really independent while mom is working. So that's kind of his normal thing of being independent while mom is working. So some recommendations, I thought that Milestones Development Tracking app, I was like, hey, this could be good for mom or even our other family, they got little kids. Like I said, you know, some support to mom just as being, I think all parents need extra support. So, you know, letting her know she's doing a great job. I thought it was amazing that she already had these strategies already in place, probably with her other son using a lot of those strategies and was really implementing it now. But yeah, it was kind of hard to say if he preferred to play on his own just because that's what he's used to. So I'd be curious in like if he was in more peer like socialization spaces, would any of that change? And I saw in Alyssa's note today, sorry to take over your space, that mom was looking at maybe getting into daycare part-time later this year. So I thought that was interesting, maybe helpful with some of his peer socialization. I threw out the DBP potty training course. Mom isn't like super, like this is a problem right now, but it's always available as it's needed. Brad did talk about the raisins and he's, to me, like typical toddler. He caught on to that super quick of like, oh, I just go and sit, now I get a raisin. So he caught on and mom basically had to kind of shut that down where he had to earn now the raisin when he pees versus trying to pee, because he was just trying to get all the raisins he could. Yeah, I was like, I would too, buddy. And then also, you know, get him involved in speech because there is still a little bit of difficulties in that area. So that is me, nice and quick. Thanks to Brad, didn't have to cover over half the stuff. So any questions for me?
Did anybody get a sense of like how long the working from home situation has been happening? I don't think he's ever, and I think I asked, I think you had mentioned too, that he's never been in a daycare or childcare setting, but like, do you know how long Tom's had this job or?
I do not. I know Brad, if you, yeah. Yeah, she did talk about how he, like, there aren't a lot of kids that he like plays with or knows. She talked about like, was it a cousin that was like 3 months different of his, but that was it. Didn't talk about any other peers that he spends time with besides his brother.
I don't have a question, but I have a compliment. So you did a great job. I really liked how you circled back several times, talking about the mother and the positive attributes that she has, the skills that she's built.
Yeah, thank you. Yeah, I mean, I was like, I wish I knew these things, you know, many years ago before Lincoln was the age now. And then I think, oh, I'm like, my kid, I gotta do better. Awesome, thank you. I get excited to see everyone else's notes.
No worries.
Yeah. Yeah, it's amazing, right? There's also like.
Should be good again.
So you.
All right, you guys ready?
Yeah.
Cool. Okay, so I'm still Haley, still the genetic counseling trainee. Something to know about me is that I hate making PowerPoints, so these slides are gonna look very familiar. Okay, so this is my evaluation. I spoke with mom over the phone to get a family history. So we'll start with family history, then go through testing, psychosocial considerations, and a conclusion. To begin, as Brad kind of walked through in his presentation, I have this family history here. I went through like a 3-generation family history to look for different concerns, developmentally, seizures, to catch things that could be genetic or related or not related. The older brother does have ADHD. He did have 2 febrile seizures as a child, but has had no other concerns since. There is a maternal uncle that has autism, and then maternal cousins. 2 boys have ADHD and 1 of the girls has autism. All review from what Brad captured. But I wanted to talk about that a little bit more in depth here. So I have a brief educational picture. If you hang on here with me. So when we think about our chromosomes, our genetic material, females typically have 2 X chromosomes and males typically have 1 X chromosome and 1 Y chromosome. When we see several male individuals within a family that have similar symptoms of, like, we're seeing like autism or ADHD in some of the male members of this family, we can possibly think that sometimes of like an X-linked condition. And that's where if there's a male, they're likely to be affected if they get that affected X chromosome from mom, but girls we might not see affected because they have 2 X chromosomes. So when we take a look at the pedigree, sorry, this is not super clear here. But okay, if you can see my mouse. So here, this arrow right here, that's Calvin, and this is his brother. And then we move up on, this is the maternal side of the family. And we see the cousin or the uncle that has autism, and then the cousins here that have ADHD and autism, and they all had an IEP in school. So in kind of thinking about this, while I just wanted to like give you this visual representation so that we see male symptoms of some of the similar things along this family tree. So coming to my differentials, I still think that a multifactorial, things that are environmental, familial, like just general like causes is the most likely still for this family, but I think that it's still of note that it could be something that is X-linked if there is something genetic going on. Fragile X ran by like in a consideration, and that was a condition that we learned about last semester. I don't think it's super likely if the individuals, particularly the males that have ADHD, if they also don't have intellectual disability. It's pretty uncommon because typically like that's one of the requirements for Fragile X. And I asked mom and she said no, but of course we don't like have their medical history fully and have all of that, but I still think it's something to just kind of consider and review when we see a family history like that. But again, I still feel like multifactorial is the most common likelihood of what's going on, but good to note. So then thinking about testing, these testing could help us find like a cause if something is going on genetic. As I stated last semester, if there is an autism diagnosis, it is supported that children with autism do have genetic testing. However, as Brad kind of talked about in his presentation, there are no other medical symptoms that Calvin has, which not that someone has to have medical symptoms to have something going on that's genetic, but it would like increase that suspicion. And a brief reminder of what the genetic testing kind of looks like for a child in this situation. There's 2 different types of testing that is kind of out there right now. This picture shows a reflex test that starts with what's called a microarray to look at missing or extra pieces of our genetic information, followed by the testing for Fragile X. Or a separate pathway is to do the autism ID panel, which looks at spelling errors in almost 3,000 genes. So they are testing different things in different ways, but there's just different options out there. In talking to mom, kind of transitioning into psychosocial history here, I enjoyed talking with her. She was very friendly. I kind of gave her, the rundown of why I was calling and talking with her, and I asked her some questions about how she was doing and any concerns that she had, and she really like didn't have much of a concern. Like she was knowing that we're going through this evaluation and we're gonna see what we're gonna, find, and happy to have all of the support from our team, but nothing extra like of concern to note there. And so my conclusion, short and sweet here, is just to wait and see kind of what the rest of the evaluations have. And then kind of decide if we want to consider testing after that. If there is an autism diagnosis, we can talk about it then. If there's not an autism diagnosis, then probably not. Cool. I know I went through that really, really quickly, but I didn't want to repeat too many of the things that have already been said by our presenters today. Does anybody have any questions? Maybe.
I know like about Fragile X, but are there other, trying to think off the top of my head, are there other like X-linked conditions that can be associated with autism or like some kind of developmental disability? I'm trying to think off the top of my head.
Not any that I can name. I'm sure there are though. Yeah.
Did you get a sense of like mom's openness or willingness to do genetic testing based on X results or?
Yeah, I mean, I kind of like, I briefed after I was like, this is who is calling you. But I gave a rundown of like, both before and after I went through the family history of like why we were asking these questions, what genetic testing might give for us. And she seemed like open to it. If we found reason to do testing, I think she would be supportive of that.
All right.
Thank you.
Yeah.